Well, welcome everyone. We're happy to spend this time during these difficult times. This is a way for us to kind of reach out. And what we're noticing within Nittany Eye Associates, of course, we're just seeing emergencies now. But what is starting to emerge within the profession is this thing called telemedicine, where we're able to talk virtually with patients, and a lot of really cool things are happening in that arena, and I think it's going to change the way that we provide eye care to patients. And so as an extension of that are these ideas of doing webinars for you, for the benefit of our patients and our patients' loved ones who want to know a little bit more about the eye condition that they or their loved ones may have. But sometimes in the exam room, things get busy and maybe you don't think about all the questions that you want to ask. So this is a format for you just to learn a little bit more about glaucoma. So let's kind of dive right in. We expect this to last no longer than a half an hour total, so we want to be respectful of your time. And so now we are going to go ahead and, okay. So these are my disclosures. I do quite a bit of research for many different companies and do a lot of glaucoma stuff. But this is really kind of where I'm coming from is that I'm both a primary care optometrist. You can see all of our docs at Nittany Eye on the left, and on the right. About 4 years ago, we started something called the Glaucoma Institute of State College, where Dr. Parekh and I work together to manage our patients with glaucoma. So that's where I'm coming from. Today, we're going to talk about the basics of glaucoma. We're just going to talk about what it is, how we treat it, some of those things, and you'll have a chance at the end to ask your questions. The eye is a hydraulic system, and what that means is it's denoting, relating to, or operated by liquid moving in a confined space under pressure. So glaucoma really is no more complicated than that. The eye is a pressure gradient system, and so my job within the management of glaucoma is to deal with this pressure gradient system. And so who else deals with hydraulic systems? Plumbers. So essentially I am an eye plumber is really what this boils down to. So a normal eye, the eye makes fluid and drains fluid. You can kind of see my cursor here. The eye makes fluid in this area, and fluid kind of comes up and drains within the anterior part of the eye. But with glaucoma, that pressure builds up within the eye. It doesn't drain in this area the way that it should, and so that pressure starts to build up and starts to push on the optic nerve, causing damage to the optic nerve. That's essentially what glaucoma is. Okay, the management of glaucoma is like a stool with three different legs. Thank you. 3 different legs. A stool with 3 different legs. One is pressure. One is the optic nerve, how it affects the optic nerve, and a third is the visual field. So using those 3 legs of the stool together, we're better able to manage your glaucoma. All right, so how do we measure glaucoma? Everyone here is familiar with the Goldman tonometer, where we put a drop inside your eye, and then we bring this blue light right here, really close to your eye, and then it actually applanates the cornea. It doesn't contact the cells directly. There's a thin layer of tears over top, but we're able to measure how much your eye resists that tonometer, and then we put that, we then transcribe that into a pressure system. That's measured in millimeters of mercury. So when I said the eye is a hydraulic system, this is how we measure the hydraulics. Okay, but there are many other different ways to measure it. On your left, you see this instrument called the ORA. It's kind of the newest and fanciest air puff test. Many of you in the past have probably heard something like, hey, I don't use the air puff test to measure your pressure in glaucoma because it's not as accurate, and that's true. But on the left, we have an air puff test that is thought to be more reliable than the Goldman test that you saw previously. On the right, we have another instrument called the eye care, and I could have put on 15 different instruments that can all measure pressure. All right, so how do we measure the optic nerve? I said that's one of the legs of the stool. How do we measure the optic nerve? So there's a couple different ways. One is to do pictures of your optic nerve. So you can kind of see here that this is a picture of the optic nerve. So we measure the horizontal difference. You see how this area is lighter in the center and a little darker around the outside. And within this whole circle is the optic nerve. So we measure the inside part of the nerve, both horizontally and vertically, and compare it to the outside. And then we put that into a cup to disc ratio that you can kind of see over here. So with glaucoma, that cup to disc ratio starts really small, but as the glaucoma gets worse, it kind of gets bigger here, and gets the biggest here. So this is a patient whose glaucoma continually is getting worse. The way we try to offset that is by lowering the eye pressure. And so another way to measure the optic nerve is an instrument called the OCT. OCT stands for optical coherence tomography. And so what we're doing with optical coherence tomography is we're taking a measurement around the optic nerve. And here you can kind of see all the different layers of the optic nerve. So we look to see how thick some of these layers are, because with glaucoma, it can thin out some of these different layers. So one of the areas we're looking at is the optic nerve head map. And so we can kind of see here, here's the anatomy. And this is the picture that I see where we measure the thickness of this layer here and this layer here, and it converts it into a picture like this. Another way that we manage it or monitor it is something called the ganglion cell complex, where we're looking at all of this anatomy right in here. We're measuring how thick all these different fibers are. And this is kind of the example of what I see as I'm looking at the report. So the nerve fiber layer is the first thing we measure, and the ganglion cell complex is the second thing we measure. But there's a new development within the field of glaucoma called OCTA. That stands for optical coherence tomography angiography. Angiography is the study of the blood vessels. So essentially, what we're looking here in our lower left-hand corner is the blood vessels coming out of the optic nerve. And here's an example of a normal patient. This is an example of mild glaucoma, and this is an example of moderate glaucoma. And we're measuring to see how much blood flow is being lost from someone who does not have glaucoma to someone who has moderate glaucoma. And so we're better able to pick up early changes within glaucoma, and we're better able to monitor progression. Another way we monitor progression is change over time. So here we're monitoring the ganglion cell complex as time goes by. Here we're measuring the nerve fiber layer as time goes by, and that's being converted into this thing that's called a trend analysis. So if we see a downward slope like this, that means that the glaucoma is getting worse. So our job is to lower the pressure enough so that this is a nice flat slope instead of a progressive slope like this. Another way that we monitor glaucoma is through the visual field test. The visual field test, you're probably familiar with it. You kind of sit within an instrument, your head's enclosed, and you look at the center part of the dome, and then lights go on in the periphery. And so you click it if you see the light, and you don't click it if you don't see a light. And so here's what a normal visual field looks like here. And as the glaucoma gets worse, kind of going down this way, then we can kind of see this patient is losing their peripheral vision because of glaucoma. So again, it's our job as clinicians to lower that eye pressure, to keep that from happening. But how do we treat it? There's many different ways of treating glaucoma. One of the most common ways is using eye drops. And as we use, there are many different types of eye drops that we can use. One of those is a prostaglandin. That's the most common type of eye drop. That includes maybe latanoprost or Travatan Z or Lumigan, but there's some really exciting new ones like Vyzulta that does everything a prostaglandin does, but it also relaxes the drainage system within the eye, which can lower pressure further. Maybe you're using a beta blocker or a carbonic anhydrase inhibitor or an alpha agonist. These are all different ways that the eye can, that we can lower pressure through the use of eye drops. If you think of the eye as a faucet with the water turned on, some of these drops is like turning down the faucet, so not as much fluid is flowing into the sink. And some of these drops are like cleaning out the drain, so more fluid could flow through, thus lowering eye pressure. Another way to treat glaucoma is through laser. There's a procedure that we commonly do within our office called SLT. That stands for selective laser trabeculoplasty. And the way that I think about it is this: the eye is an enclosed system where the eye makes fluid and the eye drains fluid through a filter, a 360-degree filter. So we could laser that filter, which then opens up the filter, that spongy filter-like material. It opens it up so more fluid can kind of flow down through that sponge, which lowers pressure. The nice thing about laser is you don't have to think about treatment on a daily basis the way that you do with eye drops. You use eye drops, you have to think about them every single day. With laser, we do it, and usually that lasts 3 to 5 years, sometimes a little longer, sometimes a little shorter, and then it can be repeated. So that's a nice option. Sometimes cataract surgery can lower pressure by opening up the drainage angle within the eye. With the drainage angle, you know how I mentioned the filter earlier? The filter is kind of right in this area. And so fluid can flow right into that filter. But every patient has something called a drainage angle. And so you may have heard of open angle glaucoma. That's when you develop glaucoma with an open angle. And then there's closed angle glaucoma, where the angle starts to get really, really narrow. And so cataract surgery can open up that angle, which a lot of times lowers pressure in patients with glaucoma. So cataract surgery alone is a nice treatment for that. We also have a range of treatments called MIGS. That stands for minimally invasive glaucoma surgeries, which are kind of like just a minimal way of reducing eye pressure using surgeries that might increase the risk a little bit, but also lowers pressure. And then in patients with really advanced glaucoma, we do something called a trabeculectomy or a tube procedure. And that's kind of the most advanced glaucoma surgery that can be done. Okay, so let's kind of give a little bit of a summary here, and that is glaucoma is all about pressure. We want to lower the eye pressure. That can be done through drops. It can be done through laser procedures. It can be done through MIGS, minimally invasive glaucoma surgeries, or it can be done through trabeculectomies or tube procedures. The glaucoma is all about the optic nerve. We really want to monitor that optic nerve closely. That can be done either through retinal photography, or it can be done through optical coherence tomography, as we mentioned before. Glaucoma can be measured by visual fields using the peripheral vision test. There's also another test that I didn't mention called ERG, electroretinogram, and that is a type of visual field that you don't have to hit the clicker as you do it. It does so automatically. And then there are many different treatments that we have for glaucoma that we talked about: drops, laser procedures, those types of things. There are many different risk factors for conversion. If your brother or sister has glaucoma, then your risk goes up significantly. If you have a parent that has glaucoma, then your risk goes up slightly. If you have a grandparent that has glaucoma, your risk goes up slightly as well. So the most important risk factor is if you have a brother or sister that has it. Smoking is a risk factor for glaucoma conversion. Low blood pressure, sleep apnea, insecticide exposure, hypertensive medications, if you take them at night before bed, that's a risk factor. Obesity, diabetes, migraines, Raynaud's, a condition called exfoliation. if you have any blood leakage off of your optic nerve, if you have something called a central corneal thickness that is really thin, that's another risk factor, or something called a lower hysteresis. Hysteresis is a measurement of how elastic your cornea is. And so we take a measurement of that. So those are all risk factors for conversion. And then there are also risk factors for progression. If you come in with a history of having a really high pressure, that is a risk factor. Or if you have a really thin cornea, or a condition called exfoliation or disc hemorrhage, the older that we get, the more chance we have of the glaucoma progressing. So these are all risk factors that we evaluate on each and every patient with glaucoma. Okay, a lot of times we say glaucoma. So we come across this type of circumstance on occasion, and that is a patient will come in and say, you know, I had this laser procedure 10 years ago and it lowered my pressure, but I'm cured now. That's not necessarily true. Glaucoma, while we have a lot of treatments, all of these treatments are temporary. And so we kind of say glaucoma is like one of these nasty people over here that just keep coming back. And that's not meant to scare anyone. It's just meant to say that we have to continually monitor our patients on a year in and year out basis to make certain that they're not progressing as time goes by. And so even our best treatments can stabilize your eyes, keep your pressure well controlled, but there's always a chance that it's going to come back. And so we have to be vigilant and be aggressive in your treatment to make sure that it doesn't come back. All right, at this point, we are happy to take questions for you. And so I think maybe Rachel is going to help me out. Okay, I actually see the first question here. Yeah. When treating glaucoma, do you usually start with drops, or is treatment decided on a case basis? Thank you for that question. And so when we talk about glaucoma treatment, we have, for mild and moderate glaucoma, it really boils down to one of two options. And this is also dependent on the patient. Do we want to start with eye drops, or do we want to start with a laser procedure? In the United States, for the longest time, most eye doctors treated patients with eye drops. It was considered a little bit safer. But a recent study came out called the LIGHT trial that looked at laser treatment as first-line therapy, and it was found that it worked equally as well, and it might be a little less expensive as time goes by for patients as well. So we think that it's really either option is a good one. Even though drops are considered a little safer, we now know that drops can cause things like dry eye. They can cause other types of side effects as well. So drops are not as harmless as we used to think, whereas the laser procedure is a little safer than we think. So we really kind of leave it up to the patient. My own biases is slightly towards laser, because one of the problems within glaucoma treatment is, can patients remember to take their drops every day? There are some patients that do a good job with that, but there are some patients that can't. And so I have a slight favoritism for the laser procedure. Good. All right, do we have any other questions here today?
I'm not seeing any just yet, but if you guys have questions, please go ahead and fill them out on that question and answer section. In the meantime, I do have one for you, Dr. Cymbor. So does glaucoma, is that only something that we see as we age, or is there a chance that you can develop that at a younger age?
Yeah, so as I mentioned, glaucoma, much greater chance of developing it and it progressing the older that we are. But these days, we're really kind of finding many younger patients are developing it. So with our more sophisticated technologies, we're finding it earlier and earlier and earlier in patients. So it used to be that it was common to make the diagnosis in our 60s, 70s, and 80s. We're now diagnosing into the 50s and sometimes even into the 40s.
All right, thank you for that. We do have a couple more questions here.
Great.
If you want to take a look, you might have a better time pronouncing some of those
Oh, sure.
words on that one for me.
No, well, why don't you give it a try, Rachel?
Well, I'll let you take the lead on that one.
All right. Has anyone ever recommended using Rhopressa with brimonidine to help relieve some of the side effects? Yeah. So that's a really good question. And so Rhopressa is an eye drop called a ROCK inhibitor, and it reduces the episcleral venous pressure, which lowers the eye pressure in general, and that can make the eye turn a little bit red. It can give the appearance that your eyes are dry and red and irritated. So there is a medication called brimonidine, which can help relieve some of those. In fact, that was brought up to me by one of our sharpest interns named Cam Rowe, who may or may not be on this lecture today. I'm not sure, but he did an amazing job bringing that up to me, and that's something that I do often these days. So thank you for that question. Can glaucoma cause blindness? Yes, as I showed earlier on the visual field, where it started off being really nice and open and clear, but as time goes by, that visual field got darker and darker and darker. It started in the peripheral vision and came in more towards the central vision. So glaucoma can cause blindness, unfortunately. However, it rarely does as long as you are following your doctor's orders, you're taking your treatment the way that you should. If you're using drops, you're using those on a regular basis, and making sure that you're following up on a regular basis. So unfortunately, it can go, but with the right treatment and the right oversight, it rarely does. Good.
Thank you for that, Dr. Cymbor. And one last question. Can you just go into a little bit more detail on what we're doing here at the Glaucoma Institute?
Yeah,
and kind of the
Glaucoma Institute of State College, we are a referral center. So we get a lot of referrals from outside doctors. And so we realized 4 years ago that the care within central Pennsylvania and the care across the nation when it comes to glaucoma is really not what it should be. And so we got together, Dr. Perek and I and our other optometrists at Nittany, and decided to start up the Glaucoma Institute of State College. And so we're getting a lot of referrals, but you don't need a referral to see us. You can refer yourself. You can do a self-referral to see us. But we offer a very high level of sophisticated glaucoma care within central Pennsylvania. And we hope to expand that with the use of telemedicine, even across the state, and who knows, maybe even further. So we're really excited about the Glaucoma Institute of State College. If you have glaucoma and you're not currently a patient here, reach out to us. We'd love to see it. Or if you have a loved one that has glaucoma that wants a second opinion, or wants to learn a little bit more about us, or just wants to get together and talk a little bit more about their glaucoma. I find that glaucoma is one of the most misunderstood eye diseases going. And so a lot of my job is just to educate our patients, to help them understand, to learn a little bit more about glaucoma. And that's what today's webinar is all about. It's an extension of what I do on a daily basis.
All right, thank you so much for that, Dr. Cymbor, and thank you for this webinar. Is really informative, and we really enjoyed it. I don't see any more questions, so I think that we have just about wrapped it up here. Thank you everyone for joining, and thank you again, Dr. Cymbor, for hosting this webinar for us.
Yeah, thank you, Rachel, and thank you to all of our attendees today. Hopefully you picked up a couple of pearls.
Thank you.